My disclosures are I'm a consultant for Globus and also for Bioventus. So today I'm going to talk about applications of lateral interbody fusion in deformity. Now, when we talk about our radiographic goals, we have a lot of these goals and we have a lot of classification systems. Schwab classification system, Rusali, we look at gap scores. But in general, I have three main goals. One is to try to get an approximate match of PI and LL. I try to establish a normal lumbar distribution index. And when possible, I'm pretty cognizant of their baseline spine anatomy and also the pelvic incidence. So if someone has a very high or very low pelvic incidence, I'm aware of that. And my clinical goals in the short term is to realign the spine, decompress the canal. And my long-term goals are to achieve a fusion. Sounds pretty simple, but the toolbox that I've traditionally had consists of two main things: Smith-Peet osteotomies with T-lifts and pedicle subtraction osteotomies. Now, each one is good and bad, and use the one that you need based on the desired amount of correction. Typically, Smith-Peet osteotomies with T-lifts were my workhorse when I didn't have a fused spine. So if I had a flexible spine, that's what I would use. But as was highlighted in the first session, T-lifts have a lot of disadvantages: cage settling, kyphosis, lack of fusion. I'm not really that patient, so I don't spend a lot of time prepping the disc space, and I traditionally have several instances of pseudoarthrosis in those cases. And you just can't get as good coronal correction. PSOs are really great and they're very powerful, and you could do asymmetric PSOs to get some coronal correction, but they have their own complications. There's several papers looking at the perioperative complications. Massive amounts of bleeding. I would routinely lose over 1 liter of blood. Durotomies, nerve injuries, and I would do about one every other week, and I still had these complications. And to me, the bigger complications are the long-term ones. Infections from a big incision that was open for a long time. Pseudoarthrosis because you're resecting a massive amount of bone. It's really hard to make that fuse, and usually older, sicker patients in PJK. So here's a case I did a while ago, pretty bad coronal and sagittal deformity. I did a PSO, and it's a decent enough correction in both planes, right? Patient did pretty well. But then they came back with this, right? They had fracture of their hardware, and this patient actually did worse after this than they did before surgery. So I somehow managed to make this person worse. And this highlights my concerns with PSOs. So then, I wanted to look at other approaches, and thoracolumbar approaches have been around for a long time. And this shark bite incision is what we used to use. I did my fellowship in 2006 with Cliff over here, and we did a lot of these approaches. We'd come pre-psoas, retract the psoas, and we used it a lot for burst fractures. We do corpectomies when we put in femoral allografts, but we also did for deformity. Funny story, it was like my first week of fellowship. I didn't know Cliff was going to be here, but my first week of fellowship, and Cliff had a dentist appointment, and he goes, yeah, just do the anterior approach and do the lateral releases. But we do this all the time. And the purpose of it was to mobilize the spine by doing annular releases and disc work. And we didn't have any lateral interbody cages, so we'd pack it with the autograft we got from the rib. And this has since evolved, and this is what we now associate with lateral interbody fusions. And in 2006, Oscar, along with Nuvasiv, came up with this minimally invasive lateral interbody fusion. Now, most of us, including myself, initially started using it for indirect decompressions, such as this patient with spinal stenosis. After a lateral interbody, their central stenosis is gone. But the main question is, can we use these techniques in deformity? Because for me, Smith-Peets and T-lifts and PSOs just weren't doing the trick. And I think Peter's here. Peter's part of ISSG, and MISTEF they came out with the MISTEF algorithm in minimally invasive techniques for deformity. This came out in 2014, and then they came out with the MISTEF 2, and they identified class 3, where they talk about the use of lateral procedures as well as expandable cage technology, and this kind of applied to what I wanted to do. But I had a few barriers for lateral interbody fusions. When you are doing lateral interbody fusions, you're taught to do it with a C-arm. You want a perfect AP, you want a perfect lateral, use fluoroscopy, and you just work in your working cannula, and that's how you stay safe. The problem with scoliosis is there's a lot of rotation. So it's really hard to get that perfect AP and perfect lateral, and if you're going to do multiple levels, you constantly need to be moving the bed in the patient. The other problem is a lot of my patients are revision, so they have multiple level laminectomies, so it's hard to know what's a true AP and a true lateral. So the thing that really changed my ability to do laterals and deformity surgery is navigation. We started using navigation for basic degen cases and then extended that to deformity cases. So now the first question I ask when I have a patient with deformity is the curve flexible or rigid? And I don't get any fancy bending films. I basically look at the CT scan. I look at the scout images a lot, and if I see a vacuum disc phenomenon like in this patient, I assume that the curve has some mobility. I don't need to see complete resolution of coronal and sagittal imbalance. Just a little bit of air in the disc space gives me some hope. So this is a patient I just did a few weeks ago, spinal cord stimulator, previous 4:1 fusion. And you can see on that scout image on the CT scan, there is some air in that disc space. So that alone lets me know that lateral interbody fusion with Smith-Peet osteotomies, removal of spinal cord stimulator, gets you a pretty good result. Also, coronal alignment is really hard to achieve with Smith-Peets and T-lifts like I talked about earlier. And even with asymmetric PSOs, it's a really challenging case. So this is a patient just from, once again, from I think last month or the month before. Pretty significant coronal imbalance with lateral listhesis at multiple levels. I tried doing a 3-level lateral, but I didn't have the corridor for the middle level. But a 2-level lateral really helped with the coronal alignment significantly. And decompress the foramen, and this patient did really well. Or so far, it's only been a month, so we'll see how she does in the long term. So the other application is anterior column releases. I started doing a lot of these a little while ago. So when I have motion and I don't need a ton of correction, I'll just do what I showed you, which is lateral interbody fusions with pretty aggressive Smith-Peet osteotomies in the back. When I need more correction, I do an anterior column release. So this is a patient from, I think, a couple of months ago. Had a 4:1 fusion done, had adjacent segment disease, had a lateral with a lateral plate done at an outside institution, and on x-rays, sagittal positive, 49 years old, couldn't really walk after this procedure. And if you look at the CT scan, you can see that the lateral interbody wasn't placed properly and the patient subsided. So it's pretty fused, it's pretty rigid down below. So in this case, I needed to get a lot of correction at the level above and also at L5S1. So this is a perfect case, in my opinion, when you have an open lateral disc to do an anterior column release. So we did an anterior column release. We got a lot of correction there, and she's fairly recent post-op, but I think we got about 30, 35 degrees of correction. And you avoid all those consequences of PSO. I mean, once again, I love doing PSOs, but I would routinely lose a liter and a half of blood, have neurological complications, and it took forever. And I'm 50, man. I get tired doing these kinds of surgeries. So this surgery is pretty straightforward, and patients do fairly well. The question we have to ask ourselves as surgeons, and I think Cliff and I have talked about this a lot, is does every deformity need to be corrected? Do we need to do T10 pelvises, T5 pelvises on every single person? And I think it's important to ask, what's the biggest source of the patient's disability? So this is a patient that I had like a year ago, 68-year-old woman with osteogenesis imperfecta. She's Michigan medium, so she's a fairly large woman. And for us, why was she hurting, right? Clearly her weight, her deformity have a big effect, but she couldn't walk very far. If you look at the MRI, she had 1-level severe central stenosis. So rather than attempt to do a big deformity case on this individual with really poor bone, a 1-level lateral with percutaneous screws was done. Now, I'm not going to pretend she's running any marathons right now, but her back pain is still present, but she can walk, and functionally we've made her better, which should be our ultimate goal in taking care of patients. The last category are rigid patients, right? So when you have a rigid deformity, it's been kind of ingrained in our heads that you need to do a 3-column osteotomy, a corner osteotomy, a pedicle subtraction osteotomy. But this is a case from, I think, a week or two ago. It was a 70-year-old patient with a remote history of 2-level A-lifts with LT cages at 4:1. Patient had adjacent segment disease and had a L1-4 laminectomy done with 3/4 T-lift and 1-4 posterior spinal fusion. You can tell that the alignment is not great. And if you look at the CAT scans, the patient is fused posterior laterally. I only have one cut, but if you scroll through it, you'll see a solid posterior lateral fusion from 1-4. What you also notice is, or what I notice is that the disc space is not fused. And even if you just do a posterior lateral fusion, sometimes you see calcification of the annulus and the disc space looks fused. So in this person, I probably traditionally would have done a PSO, worried about pseudoarthrosis, nerve injury. But instead, I went posterior first, removed the fusion mass from the back. It was posterior lateral. Did a pretty wide Smith-Peet, flip lateral, and did a anterior column release and regular lateral interbody at the level above that. And we got really good correction without any of those consequences that I worry about with the pedicle subtraction osteotomy. So is the PSO dead? Well, I mean, I used to do one every 2 weeks, right? And now I do maybe a couple, 3, 4 a year. So I wouldn't say it's dead, but I'd say it's barely alive. So the patients that I do PSOs on now would be patients with a really rigid spine with no motion in their disc space, kind of like an ankylosed spine. That'd be my only real indication. So in conclusion, I think it's important for everyone to recognize that PSOs are very morbid procedures, and I try avoiding them as much as possible. They're my last line of treatment. It's important to identify a functional deformity because of stenosis or nerve compression from a structural one. If you do have a structural deformity, if there's any air or vacuum phenomenon in that disc space, you're likely going to be able to mobilize it with a lateral and Smith-Peets. And if you need more correction than that, then you could always go ahead and do an anterior column release. Thank you very much.